Hello, everyone, and thank you for the opportunity to present today. My name is Dr. John Frew, and today I'll be presenting this talk on emerging therapies in hidradenitis suppurativa. So first of all, my conflicts of interest are here as listed, and I will be discussing some off-label therapeutics today. So overall, the main structure that I'll take is to discuss the range of current therapeutics and HS pathogenesis with some bench to bedside insights in terms of what we know about the pathogenesis of the disease and how this relates to novel therapeutics, and then to talk about some novel targets and therapeutics that are in clinical trials as well as currently in the pipeline for the following years. So first of all, in terms of current therapeutics and the current disease that we know is of HS, it's a chronic inflammatory disease with a very severe burden upon patients and their family members, with a relatively high prevalence, around 1%, although this does vary from study to study. And certainly the traditional textbook definition of pathogenesis, which we're taught, is regarding HS as a apocrine gland-rich skin follicular occlusion disorder, and that the occlusion is the initial paradigm in which results in accumulation of purulent material within the follicle, resulting in rupture and subsequent development of this chronic inflammatory drive with purulent draining sinus tunnels and hypertrophic scarring. The role of notch signaling, as well as metabolic contributions such as obesity, polycystic ovarian syndrome, smoking, and microbiological triggers, is also well established. And the current therapeutics really reflect what we know about the traditional paradigm of pathogenesis in HS, either working as keratolytic therapies, whether working on associated comorbidities, or certainly as targeting some portion of the anti-inflammatory drive against inflammation, although the most effective treatments, funnily enough, tend to be those that are targeting more of an inflammatory drive, which would seem to be quite paradoxical, seeing as we tend to think of HS as a follicular occlusion disorder. Certainly, the way to approach this would be thought to be targeting keratolytic therapies as targeting the initiating factor in terms of the disease, rather than something that is anti-inflammatory in order to prevent further nodules. So this has certainly led to a reevaluation of the paradigm of HS as possibly being a autoinflammatory disorder with subclinical inflammation as an initial trigger and follicular occlusion being a secondary phenomenon, if not occurring at the same time as this subclinical inflammation. And certainly with the majority of clinical trials that have been completed to date, we certainly know that anti-inflammatory therapies have the higher rates of clinical response, as seen here, anti-TNF alpha therapies in the Pioneer 1 and 2 study, as well as other anti-inflammatory therapies using IL-1 antagonists such as anakinra, complement inhibitors such as IFX-1, and IL-17 antagonists such as secukinumab are showing response rates around about 50 to 60%, although significantly elevated placebo response rates are also seen in placebo arms, which are more to do with the outcome measures more than anything else. So overall, the current situation is that there's a big need for novel therapies. We certainly need to move beyond repurposing of existing psoriasis drugs, and we need to understand pathogenic mechanisms in order to further our translational understanding of the disease and identify novel effective therapeutic targets. And this is where certainly some of our previous work during my time at the Rockefeller University in New York City was focused upon bench to bedside insights into the disorder. And certainly there's a lot of good work occurring globally regarding the identification of novel targets. So the two aspects of bench to bedside work in this disorder are based on the acknowledgement that there are multiple inflammatory pathways at work. This is a much more complex disease than something such as psoriasis or even atopic dermatitis. And certainly we're beginning to understand now that there may be a relationship between the varied heterogeneous morphology of the condition and differential types of inflammation that we do see within the disease. So first of all, I'll speak a little to the multiple inflammatory pathways. So we do see in a number of the observational studies that are present in HS that we have a lot of observational data regarding the role of a number of these targets in the disorder. So the thing that is seen, though, is that a lot of these studies don't really look for the mechanism or the direction of a lot of these causations. And certainly, we're only left with a moment in time snapshot in terms of the associations between disease activity and certain inflammatory pathways. And a lot of the excellent work that's been done in the past certainly does reflect that at a snapshot in time, there's definitely an upregulation of neutrophil-associated pathways such as GCSF, interferon gamma, a number of interleukins with a strong contribution from the Th17 pathways. But certainly what is missing in the overall paradigm of our understanding of these pathways is ex vivo intervention with therapeutics, and then certainly translational studies looking at the difference pre and post particular interventions. Looking further into other aspects as well, there's multiple novel cytokines that we know overlap with areas such as psoriasis, which have really been the justification for our repurposing of a number of these therapies. But certainly, we have identified recently through some of the excellent work from Europe, as well as from here in the United States by Angel Bird and her group, that there's a strong B cell and plasma cell component. And definitely, there's contribution from the inflammasome, from interleukin 1 aspects, as well as from a number of other aspects such as IL-36, IL-6, and a number of other minor pathways contributing to different subsets of T cell activation, Th22, Th17, and also in some degrees, this B cell pathway may also contribute to the high levels of acetylated histone complexes, which have been identified, and various other levels, such as elevated eosinophils and IgE, that's often seen in lesional tissue in some older studies. So the overall milieu, as we understand it as of recently, is incredibly complex. But what we don't have an understanding of is if these different morphologies have different inflammatory characteristics. Certainly, as we know that until recently, we've only really looked at the psoriasiform epidermis and not really so much at this deeper fibrosis, these deeper epithelialized tunnel structures which occur, which up until recently have been thought to be a secondary consequence of scarring and merely a conduit for pus and discharge rather than an active inflammatory organ themselves. Certainly, there is things that we can take as assumptions from previous work in inflammatory arthropathies and fibroinflammatory disorders to suggest that fibroblast subpopulations, which have previously been identified by other authors in healthy skin, may or may not be dysregulated in conditions such as HS, and certainly would explain a lot of the co-activation of certain factors, including IL-17 pathways, IL-1 beta and interferon gammas, to encourage hyperactivation of some of these neutrophils with histone scaffoldings and nets production. Also, a number of these pathways downstream of PDGFR beta subtypes of fibroblasts certainly would lead to an explanation as to a lot of the signals in cartilaginous pathways, which we do see activated in some of these fibroblasts in HS. And certainly the development of tertiary lymphoid follicles is something that may be possible to develop in HS, and certainly would be something that a contribution from a highly inflammatory fibroblast milieu would certainly contribute to and explain a lot of the features that we see histologically. Complement has recently been identified as something that's strongly associated with HS and not purely due to its involvement in neutrophil activation. Certainly from previous work, again, in other conditions, in sepsis, as well as in arthropathies, and inflammatory bowel disease, we certainly know that it can be involved in monocyte macrophage activation in mast cells, and also really the important link between microbiome dysregulation, given that a lot of species commonly seen in some types of severe HS, such as porphyromonas and peptinophilus, can cleave C5 into C5a and C5b in a similar fashion as also seen with gingivitis. And we know that that has been able to set up inflammatory pathways in other diseases, and so certainly there's a theoretical basis for this having action in HS as well. The work that's previously been done in B cells has certainly observed a number of changes in B cell populations and plasma cell activation in populations, and definitely the downstream pathways that may be functional in HS would not only be related to high levels of antibody production, but also to external effector functions, again involving downstream pathways associated with fibrosis, such as TGF-beta and IL-6, and also a further upregulation of T cell monocyte and macrophage activated factors. So there were some excellent papers that came out in JCI Insight in the last year, in 2020, which certainly identified that not only B cell levels, plasma cell levels, and not so much immunoglobulins, but certainly those activated pathways and groups can have a predictive method in terms of identifying who will respond to adalimumab therapy and who will not. And additionally, there was a really nice conclusion in terms of that TNF alpha antagonism in HS is primarily working through downregulation of B cell and plasma cell activation. So this gives us an entirely new insight in terms of how anti-TNF therapy works in this disease, and certainly explains the observations epidemiologically that individuals with large amounts of tunnels in terms of their morphology are much less likely to respond to TNF therapy due to an increased level of B cells and plasma cells surrounding those structures. And this nicely segues into the second aspect, which talks about heterogeneous morphology and inflammation. As certainly we've mentioned previously, the follicular occlusion paradigm suggests a progression from comedone to nodule to labsis to sinus tract. But this is really an assumption, and we don't have much proof to really support this. And certainly our group has recently published that there is a strong inflammatory immunological signal that we get with tunnels that is quite distinct from that of the overlying epidermis. And certainly what we can see is that primarily in severe individuals, the majority of that inflammation is actually derived from this lesional tunnel epithelium and the surrounding fibrotic stroma with accumulation of mixed inflammatory infiltrates rather than from the overlying epidermis. And this is certainly reflected not only in the tissue, but also in the serum, in that different levels of pro-inflammatory proteins are identified in proteomics in the serum of individuals, which is differentiated by their morphology, primarily whether or not they have actively draining inflamed tunnels. So the reason that this is important is not only for an understanding of how the disease works, but also in terms of how we use our outcome measures in clinical trials. And the real learning curve for this, unfortunately, has been, the brunt of it has been taken by the experience of IFX-1 and InflaRx in their SHINE phase 2b study, in which, although it had quite a significant reduction in abscess and nodule count, the placebo response rate was greater than 47%, and hence the primary outcome wasn't met. Post hoc analysis did identify that there was a statistically and clinically significant reduction in draining tunnels, but because our outcome measures don't take into account draining tunnels at the moment, this did not equate to a successful phase 2b trial. So the take-home message essentially is that HS does have different morphologies, different inflammatory pathways are reliant upon the different morphologies that exist, and certainly we have an inkling that different therapeutic targets may be appropriate based upon morphology and inflammatory profiles. This then leads to what targets are available currently in clinical trials and in the pipeline. And certainly from our recent systematic review in the JID, just released this past month, certainly indicates that a number of novel targets are present, but a large majority of them are only based on observational studies, and we don't really have the ex vivo interventional cellular-based identification of targets to really back that up. So in some degree, we are really using a trial and error and a repurposing approach still. Certainly, it's worth acknowledging that a number of these targets are working not just on the epidermis, and that certainly a lot of the ones that certainly seem most beneficial may also be working on multiple other agents. And this is a picture just derived from a recent review that we also published in Drugs of the Future. So certainly the well-established role of TNF alpha, which adalimumab is FDA approved for use of HS, is also supported by the use of other TNF alpha antagonists such as certolizumab and infliximab as off-label uses for HS, as is currently used around the world. But certainly we don't have good evidence for the use of etanercept at the moment. IL-1 antagonism is currently used off-label with the use of anakinra in a number of tertiary centres, and certainly there are ongoing trials investigating the possible use of bermekimab, a novel IL-1 alpha antagonist, and rilonacept as a fusion protein in HS. And this certainly fits with the knowledge that the TNF alpha and IL-1 cascade is primarily keratinocyte derived, but certainly we do have some evidence that IL-1 activation can very well come from both fibroblasts as well as keratinocytes. And this was well established by Kirsten Walk and Robert Sabat's group back in 2019 with a nice paper from the JID. So even though the initial premise was to block it in a similar way with psoriasis with epidermal targeting, it may also be working on some of these activated fibroblasts. In terms of other targets currently in clinical trials, IL-17 and 23 antagonism is, again, largely co-adopted from their use in psoriasis. And a lot of the observational data that we have is purely because we've acknowledged the histopathological correlates between psoriasiform hyperplasia in both conditions. But certainly we don't have a lot of understanding about the role of IL-17 and IL-23 in some of these deeper structures with tunnels, and certainly on the role of B cells and fibroblasts. In terms of complement antagonism, despite the issue with outcome measures, it's still an area of deep investigation with ongoing trials. And certainly, largely driven by the Europeans and the French, the ongoing use of antibiotics in combination as well as with intensive suppressive therapy is ongoing in trials as well, although the results are rather mixed. So our experience with the clinical trials and translational work that we are currently completing with brodalumab, an IL-17 RA antagonist, certainly does show that suppressing multiple types of IL-17 isoforms, including A, C, and F, can be more effective. And there is some preliminary results out from a trial with bimekizumab suggesting that in a subset of patients that it may have a very excellent degree of disease suppression. Secukinumab and ixekizumab are a little bit mixed, and unfortunately the phase 2 results of guselkumab and risankizumab are still currently unavailable, but we're hopeful that positive results will be seen. Certainly our experience with brodalumab in a very small open label cohort did show a large degree of suppression with a significant minority of patients achieving complete resolution of abscesses and nodules, although there certainly was a subpopulation of patients with draining tunnels that we found that it was less effective. So certainly something that has similarities to adalimumab. In terms of complement, it may be that there are overlaps with the role of neutrophils, but certainly the role of bacterial and B cell responses in the disorder certainly make it quite an interesting target to further explore. And the use of IFX-1, either as an IV or subcutaneous administered dose, or avacopan as a C5aR antagonist and an orally dosed medication certainly is of interest in future trials of HS. And this is largely something that does fit into the role of the microbiome in HS. And certainly it's an ongoing emerging field in terms of that we know that targeting the microbiome solely has variable responses, but certainly the use of acute suppressive therapy such as IV ertapenem can be very, very effective in a subset of severe patients. In terms of other things that are currently in trials, JAK inhibitors are also of interest. There certainly are small case series and cohort studies, but again, we don't have too much clinical data regarding these. Other interesting aspects of the JAK pathway may be that they have multiple targets, including being able to target IL-1, TNF alpha-based expression, interferon gamma expression, as well as certain aspects of B cells and type 1 interferon responses, largely through JAK1 and TYK2 suppression. Additionally, the role of the Th17 pathway via TYK2 is of interest, given the multiple cytokines that can be suppressed with JAK-STAT inhibition. Certainly, there is a potential with JAK2 inhibition that IL-6 and aspects of granular poiesis can also be suppressed with some of those targets. And definitely combined suppression of JAK1 and JAK2 is something that would be of interest to explore ex vivo. And certainly there are suggestions afoot that trials of broader JAK suppression may be useful, although the safety of those certainly need to be explored. The other interesting thing in terms of treating disease and comorbidities is that anemia, which is a significant burden in HS, could also be beneficially treated through the use of JAK therapy, given that the role of erythropoiesis is linked to JAK activation. Although conversely, it could also worsen side effects such as pancytopenia. So obviously that's a consideration with the use of JAK inhibitors in this disease. Other potential targets, which are probably the most interesting, the most exciting in my opinion, would be IL-36 antagonism, particularly off the back of the results seen with spoziolimab in pustular psoriasis, and also B-cell targets, particularly now that we know that TNF-alpha antagonism works via B-cell targets, particularly Bruton tyrosine kinase and SYK, spleen tyrosine kinase inhibition. So both of these targets certainly have roles in not only the epithelial portion of HS, but certainly the neutrophil-associated chemokines and the activation of dendritic cells, monocytes, macrophages, and T cells in the disease as well. In terms of the evidence surrounding the role of B cells, we certainly have some really nice observational data from the group which published in JCI Insight, suggesting that SYK and BTK are active, both in their phosphorylated and unphosphorylated forms within tissue, and certainly surrounding these deeper tunnels. And so certainly for more severe disease, targeted B-cell therapeutics would be a very interesting option to explore, and certainly there are plans afoot for open label observational studies as a proof of concept with these targets. So overall, as a summary, I've hoped that I've been able to explore with you today the multiple insights into novel aspects of HS pathogenesis, that is not just an epidermal disorder, and certainly that morphological heterogeneity can play a big role in terms of the targets which may be appropriate for these patients. So certainly the exciting targets on the horizon would include potentially the clinical utility of IL-17 and 23 inhibitors, complement, JAK inhibitors, and the two ones which I would be very hopeful and very interested to see initial preliminary results for would be spoziolimab and IL-36 antagonism, as well as more targeted B-cell, Bruton tyrosine kinase, and SYK antagonism. So thank you very much for the opportunity to speak today. I've just recently returned back to Sydney, Australia after an exciting time in the United States. And I thank you very much for the opportunity to speak and the organisers of the MDS this year. So thank you.